the very start of the cascade. When a pathogen breaches a cellular barrier, it initiates an immediate biological reaction. To understand how this microscopic breach escalates into systemic shock, we are building a clinical continuum map. The baseline of this continuum is infection. This is the invasion of normally sterile tissues by microorganisms, specifically viruses, bacteria, fungi, or parasites. Looking at this core formula, sepsis is defined as the body's systemic inflammatory response to that infection. An infectious focus plus SIRS equals sepsis. SIRS, or Systemic Inflammatory Response Syndrome, is a strict clinical classification requiring specific biological thresholds. The first two criteria evaluate temperature and heart rate. The patient must present a temperature above 38 degrees Celsius or below 36 degrees, and a heart rate exceeding 90 beats per minute. The remaining criteria track a respiratory rate above 20 cycles per minute and a leukocyte count surging past 12,000 or dropping below 4,000 per cubic millimeter. To be classified as having SIRS, a patient must meet a mandatory diagnostic threshold of at least two of these four criteria. Clinicians should note that SIRS is a nonspecific response. Trauma or burns can trigger it without any pathogen present. The presence of SIRS alone is insufficient to prove sepsis without a confirmed infectious focus. This severity continuum outlines a progressive deterioration of patient stability rather than just a worsening of isolated symptoms. Moving down the ladder, we define severe sepsis through its first primary diagnostic pathway, baseline sepsis that is now combined with new organ dysfunction. Alternatively, a patient meets the criteria for severe sepsis if they present with arterial hypotension that still responds to fluid resuscitation. That organ dysfunction typically targets the kidneys first, indicated by oliguria or complete anuria, or it impacts the brain, presenting as consciousness disorders. Dysfunction also manifests in the lungs as acute respiratory distress syndrome, or ARDS, and disrupts coagulation, leading to disseminated intravascular coagulation. The ultimate critical state is septic shock. This is characterized by persistent arterial hypotension that fails to correct despite adequate fluid resuscitation. At this stage, maintaining blood pressure clinically requires the continuous use of vasoactive drugs, primarily norepinephrine. The severity continuum represents a strict timeline of failing physiology. If intervention is not aggressive, a patient will inevitably step down this ladder toward full circulatory collapse. Looking at the cellular mechanics, the pathogen is the starting trigger that inappropriately hyperactivates the body's defense networks. The first reactive pathway involves leukocytes. They mobilize and release a flood of inflammatory mediators, specifically cytokines and proteases. Simultaneously, the complement and coagulation pathways activate. The coagulation sequence is heavily dependent on the involvement of tissue factor. These three independent pathways converge to cause the central pathophysiological event of sepsis, severe microvascular lesions. These lesions have immediate deadly consequences. The first is a rapid increase in capillary permeability, allowing fluid to literally leak out of the bloodstream. The second consequence is profound vasodilation, resulting in a massive systemic drop in blood pressure. The third is a cascade of widespread coagulation disorders that choke the microcirculation with clots. Septic shock represents the host's own misdirected, unregulated vascular response, destroying the circulatory system from the inside out. Because this destruction occurs system-wide, the clinical presentation is polymorphic. Sepsis varies widely between patients. This variability is driven by the specific site of infection, the pathogen involved, and any underlying diseases the patient already carries. To accurately assess the patient, clinicians must strictly separate signs of the causal infection from signs of organ dysfunction. Cardiovascular dysfunction maps to hypotension, cold extremities, tachycardia, cyanosis, and mottling. Nephrological dysfunction is indicated by oliguria. Neurological dysfunction surfaces as confusion, coma, and behavioral disorders, while gastrointestinal failure typically presents as paralytic ileus. Pulmonary dysfunction maps to respiratory distress, polyapnea, and ARDS, often accompanied by isolated cutaneous dysfunction like skin mottling. These organ dysfunction signs act as universal systemic alarms. They indicate microvascular collapse, regardless of where the original infection actually started. In contrast to organ dysfunction, clinical orientation signs are used specifically to hunt down the original infectious etiology. A murmur or signs of heart failure orient toward a cardiovascular etiology, while specific lumbar pain suggests a urinary source. Meningeal syndrome and focal signs point to a neurological focus. A cough, sputum, or an oscillatory focus direct the clinician to the lungs. Diarrhea or obstruction orient to the gastroenterological system, and purpura indicates a cutaneous infection. In the exam room, clinicians must separate organ dysfunction signs from etiological orientation signs, as they serve different diagnostic purposes. To monitor systemic microvascular distress in real time, clinicians assess the 3 warning windows of the body. The skin warns of distress through sweating, mottling, and a prolonged capillary refill time. Meanwhile, the kidneys signal failure via oliguria. The brain alerts clinicians through sudden confusion and drowsiness. These 3 windows offer the fastest, non-invasive method to measure systemic deterioration while waiting for lab results to return. To definitively assess the internal visceral impact of sepsis, specific biological tests are required. Specific metabolic markers track acidosis and hyperkalemia. Among these, lactate measurement is the most critical singular test, as it directly quantifies tissue hypoperfusion. Renal impact is quantified by increased urea and creatinine, while hepatic failure is marked by increased transaminases and bilirubin. Coagulation impact appears as a decrease in prothrombin time and platelets. While processing these tests, clinicians must systematically hunt through 6 common infectious foci: pulmonary, urinary, digestive, skin, cardiac, or other systems. Biological tests confirm and quantify the severity of systemic collapse, providing the measurable data that validates the physical distress observed in the clinical windows. Immediate management is structured around 3 non-negotiable pillars. Pillar 1 is the constant progression tracking and reassessment of the patient's biological and clinical state. Pillar 2, do not wait for hypotension to act. Intervene at the very first signs of tissue hypoperfusion. Pillar 3 requires the immediate initiation of adapted antibiotic therapy, guided by the suspected etiology. Looking at the complete continuum, sepsis begins with an infectious focus and SIRS, which rapidly triggers leukocyte, complement, and coagulation cascades. These cascades cause microvascular lesions, driving the patient down the severity continuum, from sepsis to severe sepsis to septic shock, marked by distinct clinical and biological failures. Ultimately, managing sepsis is a race to identify polymorphic clinical signs and deploy targeted antibiotics and fluid support before microvascular lesions cause irreversible organ death. Prepared by Pharmatica.